Our health secretary, Dr. Nate Smith with the Arkansas Department of Health, is joining me now via Skype. Thanks for being here, Dr. Smith. And we're going to begin with my first question. Has the outbreak here departed in any significant way from how it emerged from China? And has the data trended away from the 80% mild, 15% severe, 5% critical percentages that they initially gave?
I think what we're seeing here in Arkansas is different than what they saw in China and what they've seen in maybe some of the more urban areas. We're seeing a lot of little introductions from out-of-state travel, a few from international travel. So what we're seeing in Arkansas, I'm not sure we've seen exactly anyplace else, but I think we're seeing basically the same breakdown. We don't know exactly how many we have because we haven't been able to test everyone in the state. But we are seeing a smaller proportion that need to be in the hospital. Most people are getting a little bit sick and then getting over it.
To that question of testing, Dr. Smith, that's my next question. Are these accurate numbers of people who actually have the virus in Arkansas? We're only on average, by my best guesstimate, just doing simple math, we're only testing about 125 patients per day.
That's correct. We certainly don't have all the information that we'd like to have. We do have tests from most parts of the state, and I can firmly say those who test positive are cases, but there are others out there who have symptoms or maybe have mild disease, haven't come to get tested. We don't have information on all of them yet.
We're not going to get the ubiquitous testing, though, that it would appear that we keep hearing from the federal government that everyone should be able to have a test. Does this hamper the efforts to move from a total shutdown to one where, only certain groups are quarantined, but others may go back to work or school?
Certainly, as we get more information, it'll be easier for us to make some of those decisions. I think that we know what we need to do. We've taken some pretty aggressive actions. We've closed the schools for on-site education. We've closed restaurants and bars for dine-in, etc. We've now have a directive to avoid social gatherings of 10 or more, and there have been selected places that we've also closed down by directive. So I think we're doing the right things. We're doing the things that we know are going to decrease transmission, decrease the spread. It would be nice to have more information, but we are able to test the ones who are at highest risk of COVID-19 or at highest risk of complications.
A lot of experts have weighed in on how many undiagnosed, mild, or asymptomatic people there are out there. You're a specialist in infectious disease. Can you give an estimate of how many you think are really out there?
Well, we don't really know, because even a country like South Korea, where they've tested lots and lots of people, they haven't tested everyone. And so that's really going to be eventually a question that researchers will answer in retrospect. We're in the thick of things now. Remember, this is a virus that was first reported December 31st, so we've not even had 3 months of experience with it. So we're learning every day new things. What we can say is that most people have mild disease, but we do have some who have severe disease, and those are the ones we're most concerned about.
Absolutely, Dr. Smith. Can you clarify to that point symptoms? As you just said, you're still learning about this, but some people are telling us stories where they've had no fever, but maybe bad stomach problems, or they just had a really mild cough. Is there specific symptoms that people can look to think or know they might have it?
The most common symptoms are fever, a sense of just what we call malaise, just feeling poor, weak, fatigued, and then cough, usually a non-productive cough. And those who go on to develop severe illness, they tend to have cough and then shortness of breath, and then symptoms of pneumonia. Other symptoms have been reported, some GI symptoms. In patients who have more severe disease, there seems to be some heart involvement as well, some cardiac involvement. So we're still learning a lot of things about this virus, but what we're looking for most are people who have respiratory symptoms, especially those that progress and might need to be admitted for pneumonia.
Anecdotally, we're hearing from people too about testing. Some are having to wait up to 2 weeks for their test results. I'm assuming those results are coming from private labs. Is that correct? And how many can we actually test today in Arkansas if we had to?
Well, again, most of our lab results are coming from commercial labs now, and that's where we want to be. You know, for most tests that are done for any disease in Arkansas or throughout the United States, it's mostly commercial labs and hospital labs that provide that information. We're getting there with COVID-19. We're not there yet. The commercial labs don't have the capacity that they're working to get. Of course, the demand for these tests has been much higher than the supply. But we're getting more results from private labs. Some of them we're getting pretty good turnaround. Some of them about 2 days. But others that have received a large number of specimens are pretty backlogged, and then they have problems with getting reagents to do the tests. And so I have heard of people waiting more than a week to get their results, which is very frustrating, especially if a patient is sick or getting sicker.
You estimate, though, that the numbers of tests that you'll be able to give, not only through the Department of Health, but at UAMS or any really doctor's office, will increase?
Yes, we absolutely expect that to happen. We have increased ours. We are facing some challenges with reagents, as is UAMS. Both UAMS and the Department of Health are standing up multiple platforms. So we're not just dependent on one company and one type of test. We're looking to bring another one on using some equipment we already have that now has a test associated with it that's been approved. UAMS is hoping to get 2 other platforms, so they have 3 platforms going. Again, we're not there yet, but we're getting there. Eventually, we'll have that capacity. For right now, we know what to do with people who are very sick. We can get their testing done very quickly, but it's mostly people who have milder symptoms who are concerned and would like to know, and we'd like to know as well. It's a little frustrating that we're not able to test everyone who may have the infection.
Of those people who've recovered so far, what is their average recovery time?
The average recovery time for them to be classified as recovered by our standards is a week after the onset of symptoms. Now, some people who have been much sicker, it may take longer than that, but most people who have mild disease, we will classify them as being recovered within 7 days after they first experience symptoms.
Now, you've said that you know that people could potentially be contagious before they show symptoms, but when do they stop being contagious? After that week has passed?
I think that can depend a little bit on very sick patients. For example, hospitalized patients, what we really want to do is we want to see negative test results, not once but twice, before we consider them no longer communicable. For milder disease, it's felt that, again, 7 days after onset of symptoms, or at least 3 days after resolution of their fever, they are no longer communicable.
Let's talk about the model that you all showed today at the governor's press conference, estimating in 2 weeks about 3,500 cases. Is that alarming to you? How concerning is that? Do you think that that is about where we will be in 2 weeks? And what date range are you anticipating the peak of this here in the state?
Well, those are two separate questions. Our model is really trying to give us some idea of where we could expect to be within the next week or two. And I think probably that's a good estimate. What we've seen in other places is that once the infection gets going in the community, it can increase at really pretty rapid rates. What we've tried to do is to take the data that we have, which is really not that long, a little over 2 weeks worth of data points, and try and project out over time. Again, our our model may not be entirely accurate. There's some margin of error there, but that's our best estimate of where we're likely to be. Again, as the governor has said, we can change that. Our data points up to this point were mostly before we implemented the closure of schools, the closure of bars and restaurants, the directive on avoiding social gatherings of 10 or more people. It'll take us probably 2 or 3 weeks before we'll really fully see the impact of those measures.
And then the date range, if you would. I apologize for not making it clear and kind of lumping those two questions together, but what is your date range as far as, I know the governor earlier mentioned late April as a time when he believed it would peak?
Well, we cannot at this point estimate the peak based on the data points that we have. They can give us an idea of where we might be if the current trends continue over the next couple of weeks, but they can't tell us when we're going to peak. For that, we have to turn to more sophisticated models that are really looking at population characteristics, things that we know about this virus from other places, and basically work through models that have been developed from other places rather than from Arkansas. As you can imagine, Arkansas and New York City are very different places, different population densities, et cetera. And what we've done here to address the spread of COVID-19 is a little bit different than other states or other jurisdictions have done. So there's some limitations to these models. I mentioned in our press conference earlier today that we have some models that have been put together to look at Arkansas-specific projections, and they range widely. I mentioned the Washington University model, which has us peaking fairly early. April 25th is what that model has for us, with a peak number of hospitalized patients at a bit over 2,000. Whereas other models, for example, University of Pennsylvania, has us peaking much later, the first week of June, and much higher numbers of inpatients, of hospitalized patients at the peak, more like 15,000. There's a big difference between 2,000 and 15,000, and there's a big difference between April 25th and the first week of June.
Well, there certainly is. You mentioned population characteristics in our state. We do have a bit of an elderly population. In some cases, we don't rank very well when it comes to heart disease or pulmonary disease. How fearful are you? This is a deadly virus, and I know you're expecting fatalities.
Yes, and unfortunately, we've already had 3 so far. We do have vulnerable populations in our state. We have retirees. We have people who are in poor health. The population that I'm probably most concerned about are those who are in long-term care facilities, particularly nursing homes. And we've been watching those populations very carefully. We have had now 4 nursing homes in which we've had 1 or more cases. Fortunately, in 3 of those instances, it's only been 1 or 2. It was just the one nursing home here in Little Rock where we had multiple cases. And it does seem that we're not seeing new cases there, at least not at this time.
How many patients under, I guess the age of 50 or 55, say, have had to have been on a ventilator? Are there severe cases among that population? Yes,
we've had a number of patients who've been on a ventilator. I don't have that number right in front of me, but it's not just been older individuals. It's also been some of the younger patients, younger than the age 60, under age 65, who have also required ventilatory support. Fortunately, many of them have come off of that and done well, but others are still on a ventilator at this time.
You have to be concerned, Dr. Smith, about the specifically the Briarwood community, where there are 40+ patients suffering there, and the case in Cleburne County where members of a church community came, over 30 members there. How concerned are you for them?
Well, I am very concerned, and these are the types of situations that we really want to avoid. The social gatherings of more than 10 are real opportunities for COVID-19 to spread quickly, and that was an example where a group there, I believe they were over 30 individuals who were infected, and some of them became more severely ill. So that's why we're trying to control the number of gatherings like that, because you can get rapid spread in that setting. And of course, the nursing home setting we've been very concerned about. That's why our nursing homes, our long-term care facilities, have really restricted, basically eliminated visitors from the outside during this time when we have COVID-19 in our communities.
And speaking about how transmissible it is, you know, we've read it can live on surfaces, on the bottom of shoes. Can you verify for us just how people can you pick it up if I touch a surface that you've touched and you were a known carrier of the virus?
You know, that there's still a lot of questions that are unanswered. When we've seen cases and been able to trace them back to a source, it's generally been to a person they've come in contact with, as opposed to a surface or something like that. But I think we do have to be careful. We do know that it can persist on surfaces for some period of time. How viable the virus is, how likely it is to infect someone from a surface, that we don't know at this point. But it's prudent, especially things like door handles and other surfaces that other people touch frequently. If you touch those, it's a good idea to wash your hands or to use a hand sanitizer.
Very good. Is there any other information you want the public to know or be aware of, or any message you need to get out there tonight?
Most important message for all of us is that what we do now can affect our situation down the road. If we can limit our social contacts, if we can be really strict about hand washing and social distancing, these are things that we know can reduce the number of infections, reduce the spread of COVID-19, and then avoid hospitalizations, avoid people having to be on ventilators, and avoid many of these really terrible situations that we've heard about in places like Italy and now New York City. What we do now will make a difference if we take action.
Dr. Nate Smith, our health secretary for the state of Arkansas, thank you so much.
Thank you.